Well, thank you, John. If I'd been told that I was going to have to follow the magician, I would have at least put some pictures of kangaroos and koalas on my slides. And I would never have predicted that I'd be up here talking about bone-anchored hearing aids, because I always was a bit skeptical. I thought that bone-anchored hearing aids were really for those surgeons who couldn't get a dry mastoid cavity or couldn't do a stapedectomy. But I think there is a very, very significant place for bone conduction hearing and for bone-anchored aids, and it's going to increase. And it's over 40 years since it was first recognised, osseointegration, and then that was popularised by the Swedes to show that you could connect a hearing aid to the osseointegrated screw fixture and directly stimulate the cochlea and provide good hearing and worthwhile hearing. So what's the position and the role? Well, for conductive or mixed hearing loss and single-sided deafness, there are really multiple opportunities and options. And it's one of the problems these days is that we've got too many options, and it's often hard to decide what's the appropriate intervention. Standard air conduction aids can provide a benefit. The bone conduction aids include both the passive ones, the Cochlear Baha, the Otocon Ponto, and then the passive ones, also transcutaneous, so percutaneous or transcutaneous, the Sophono, and now the active bone conduction aids such as the Bone Bridge. Then, of course, there's middle ear implants, which include the Met and Carina, which was previously made by Otology, now by Cochlear, and the Vibrant Sound Bridge by Med-El. And then there's the Codax, or Cochlear Direct Acoustic Cochlear Stimulator, and even cochlear implants for those with more advanced mixed losses. So although we've seen wonderful middle ear reconstructive surgery here, in fact, it's not always possible to achieve that, and certainly for certain patients with atresia, certain patients with intractable eustachian tube problems and middle ear issues, you can't reconstruct the air conduction hearing. And those, of course, with single-sided deafness, particularly if they've got long duration deafness, they're not suitable for cochlear implants, which is these days is an option. And so bone conduction is really a very useful indication or treatment. The indication, generally, you need bone conduction thresholds less than 45 dB, and that limits the access for many patients, unfortunately. So a couple of examples. Treacher-Collins syndrome, unreconstructable, a very advanced conductive hearing loss. A mixed hearing loss here with sloping centroneural loss in combination with a conductive loss with childhood middle ear pathology, deep medial canal fibrosis, single-sided deafness after I've taken out an acoustic neuroma unsuccessfully to preserve the hearing, or congenital hearing loss. And this is perhaps one of the best treatments for bone conduction, is where you've got single-sided deafness and a conductive loss in their only hearing ear. The conductive loss is such that they don't get much benefit with an air conduction aid, and you can provide bone conduction from the contralateral side. Previous studies have demonstrated that if the conductive loss is greater than 30 dB, then in fact bone conduction might be a more preferable and effective amplification choice than air conduction. And it exceeds conventional hearing aids when you have a mixed loss, and particularly the UK experience is that if you've got a troublesome mastoid cavity, then you can in fact improve that by not having an air conduction aid that occludes the cavity. And whilst there are now other options such as cochlear implantation or the modern cross aids are very effective, a Baha is a very effective solution for single-sided deafness. And here's an example, a patient of mine who had managed for a long time, you can see his age, with a standard air bone conductor, and he does extremely well and much more comfortable, much more effective with bilateral percutaneous bone-anchored hearing aids. But the past, in terms of bone conduction, was not pretty. it's nice to see such an excellent pinna reconstruction and then have to create a huge soft tissue defect behind the ear, which was for many years the traditional approach. Not only thin the skin, but remove all the subcutaneous tissue around the abutment. And so this was cosmetically unattractive. There was the alopecia and the scarring, but also considerable soft tissue problems at times. Whilst many were very stable and got excellent benefit, many had significant problems. And when problems did occur, it wasn't pretty at all. And there's been all sorts of reported incident rates up to around 40% for the need for revision surgeries. And also, when infection occurs around the abutment, then there can be more serious problems like osteomyelitis, loss of the fixture, or even intracranial infection has been reported. Back in 2009, and I was influenced by Gordon Su in Hong Kong, who had suggested that you didn't need to reduce the soft tissue if you used a linear incision and a longer abutment. And we did cases and reported this from Melbourne, and it was very effective. But it was Malu Hulkrantz in Sweden who has popularised this, and I'm not sure whether she learned from Gordon as well, or who really originated this. But it became really very popular as either putting the abutment and the fixture through the incision or as an offset placement through a punch hole, but certainly dramatically increased a better cosmesis, faster healing, and more cosmetically effective or acceptable. In Melbourne, in my hands, certainly it made a big difference, and I was much happier to be advising percutaneous implants. And since then, the companies have produced better percutaneous prostheses. The screw fixture is improved to have special coatings, titanium coatings on the fixture, which allow more rapid integration and greater stability. And in theory, the abutment itself has better soft tissue interaction, although, to be honest, I don't think that is a significant factor. I think what makes the difference is optimal clearance from the skin, and that the abutment itself should have at least 4 millimetres clearance so that you're not traumatising the adjacent skin. And I'm not entirely sure that the hydroxyl apatite coating makes any difference. And these days it's a very competitive market. Oticon produced the Ponto system, and again several sizes are designed to provide that clearance of the skin without the need for soft tissue subcutaneous reduction. You will have seen, and in fact I think just outside, they're advertising the minimally invasive system, which is nice. I've used it for one case, but it is somewhat blind, and the idea is that you just do a punch hole through the skin, palpate the depth, clear the periosteum, and then with appropriate irrigation use a drill system to drill a guide hole, and then a widening drill, and then the screw fixture is then, together with the abutment, is then screwed into position. And although in my one case it worked well, I was concerned to see that at the recent Osseo meeting in Nijmegen, that there are significantly high incidences of fixture failure rate occurring. Birmingham have a rate of around 35%, elsewhere between 12 and up as high as 27 or 17, and there are other anecdotally reported surgeons who have higher than usual failure rates. So it's either something to do with the surgical technique or failure of cooling due to lack of irrigation, or possibly the nature of the drill that's used itself. But something to be cautious about, although it is more minimally invasive, is a potential problem. So here's another one of my patients, atresia, and a chap in his 60s, 70s who had a successful percutaneous abutment, does very well, But then he comes along one day and he's left it off for a little while. He's gone to Queensland and it's sunny and warm, and the tissue's grown over, and actually quite simple to resect that and get him back to using it, but it's a problem. So this has led to a great interest in a transcutaneous system, and the first available really commercially that was useful was the Sophono, and this shows this dual magnet system with a number of points of screw fixation. This was the original sound processor, but the sound conduction was not particularly effective, and so they really had to have very good bone conduction thresholds to use this. Are we back on air? Thank you. They now have a more up-to-date sound processor, and Sophono as a company, I believe, have been taken over by Medtronic, and so perhaps this will be further improved. Cochlear followed with the Baha Retract system, which again is a transcutaneous system using the same single point screw fixation with an internal magnet. And in theory, and I believe that temporal bone studies have demonstrated that if you have single point fixation rather than multiple points of screw fixation, that does give more effective sound conduction. And we conducted the first clinical trial in Melbourne, and it's relatively straightforward. You mark the site that you wanted the magnet to be, the skin depth is measured, a curved incision, the site is again identified with a clearance around for the incision. A screw fixture is put in the usual manner, and we could, at least in the study, measure the implant stability quotient. But more importantly, a bone bed indicator is used to confirm clearance that the magnet won't be impacting on the bone or affecting the placement of the tightness of your screw fixation. And then the magnet is positioned and tightened with a torque wrench. The wound is closed, and once it's healed, then the transcutaneous magnetic held attachment is used. In terms of the performance, effectively a good benefit with the aided system, but basically the same as the Baha on the soft band. So no improved benefit from what they get with a soft band. And this demonstrates that there is this relatively limited high-frequency response. And as we heard from a number of our previous speakers, that this high-frequency amplification and hearing is terribly important for speech perception, and is one of the limitations of bone-anchored hearing aids. There was a lot of studies done looking at retention of the system, as well as the pressure applied through the magnet. And the device has a soft pad that goes under the external magnet, but even with this, you have to be careful that the patients don't wear it when there's any discomfort, because they can get pressure necrosis. And whilst it's not I can't show a picture because they're not my patient, I've seen severe pressure necrosis requiring significant revision surgery. But this is a great system, and it is very good, particularly for kids with atresia, and it works well. These children, of course, have normal bone conduction thresholds, and to have a Baha Retract is better than having a headband and the old-fashioned bone conduction aids. And it is possible to convert the previous transcutaneous, even where there was extensive soft tissue resection and skin grafting, convert to a transcutaneous system. And this is from one of my colleagues in New Zealand, showing how you can raise the skin flap, remove the screw fixture, a couple of rotation skin flaps, and once that's healed, not terribly cosmetic there, but then successfully use the Baha system. So the other currently available system is the because of trouble with managing the percutaneous fixture. If you've got a percutaneous thing, they do require frequent care. We describe it as like having an extra tooth. You've got to look after it. and the incidence of infection and flare-up and needing treatment is very real. So the transcutaneous systems avoid that, but the problem with the transcutaneous magnetic attract ones is that there is a loss of sound conduction and so power, and potentially the active ones can provide better power, and the Med-El bone bridge is available, but the problem is that this is really quite a big bulky device, and I believe 9 millimeters in depth. I personally don't have experience with this. The indications for single-sided deafness, you really have to have normal hearing in the good ear. For mixed conductive losses, in theory up to 45 dB, but the 45 might be starting to get to the margin of benefit. And here's an atresia girl, courtesy of George Sprinzel, just showing the incision used to place the bone bridge. And this is a mastoid placement, so the position is marked and really a sizable, well drilled, and then the device secured, and then that can be covered. And the receiver stimulator is really the same as you saw in the surgery this morning for the VSB. So the future. The future, I think, is going to be better versions of the active transcutaneous systems. And I can only show you a limited amount of this. This is from a presentation I gave recently at the Osseo meeting of our first experience with what is an investigational device. And so this is the Osseo system from Cochlear, which is a piezoelectric transducer, the active component of the bone anchored hearing aid, once again fixed to a single point transmission, the BI300 implant, and using what is basically a cochlear implant receiver stimulator as a subcutaneous component to provide, which is then powered, and the signal provided by an externally worn sound processor. Some special surgical tools have been developed to facilitate this, as well as an intraoperative test system, and of course appropriate fitting software. From a surgical point of view, it's really a combination of the Baha Retract as well as placing the receiver stimulator package for a cochlear implant. And in Melbourne, we've implanted 6 patients, all of them adults. And the first one, whose audio I showed you earlier, is a Treacher Collins lady, and she's worn a lifelong bone conduction headband. And the others are single-sided deafness of various types, and one's got mixed loss. And you'll recognise Saji here, who spent a month with me recently and provided refereeing and oversight for these cases. And he, in fact, befriended one of the patients who took him out for dinner and looked after him. And Saji's had probably more follow-up than I have about the outcomes. The surgery is pretty straightforward, so here's planning the position of the actuator and the receiver stimulator package, and we use a variety of incisions, either an anteriorly based scalp flap or in other cases a posteriorly based flap, taking care to see where the spectacles were or where people wore hats and things like that. And there's the screw fixture in place with a guide pin in situ, and then once that's in position, then we can use a bone bed indicator once again, and also plan where the cable exit guide goes. And then a template is used for the actuator to be sure it will position. And then a pocket for the receiver stimulator package and a well. This is the same as a Freedom implant, so it's got a pedestal on the base of the implant. And then the intraoperative testing is done by suspending the device in a silicon sort of package just to check that it functions. And then once we confirm it's functioning, then the actuator is secured to the internal screw fixture with a torque wrench again. Its incision's closed, and then this is the post-operative appearance. So the preliminary outcomes are that this has been successful in all 6 patients. As I said, we use some variation in incision site and actuator placement. but there have been no complications of significance. This chap had a small hematoma which resolved, and another patient had some otitis externa. And importantly, the fitting has been successful and all of them have had good clinical benefit. So this is the first subject, as I say, with a pretty maximal conductive hearing loss. And then this is her unaided thresholds, and this is the aided threshold with the BP 110, so that's a power Baha on a soft band, and then with the osseous system. And most interestingly is that in the high frequency, they get very good high frequency gain. This is sentence testing in noise. Unaided, she struggles, but with the soft band, with the power does much better, and slightly better again with the implant system, the osseous system. And hearing performance in quiet, again, not much at all without some sort of hearing aid, but then with a soft band, and then a little bit better at 50 dB, at 65 and 80, pretty similar between the soft band or the osseous system. Single-sided deafness, and the ear was plugged. The other ear was plugged for all testing with the device. Once again, the unaided, and then aided with the soft band in purple, and the aided with the osseous in blue. And once again, good high-frequency response as a transcranial stimulation. And once again, excellent benefit in speech reception in noise. And once again, good aided benefit, but at the higher presentation level, pretty similar to the soft band. And the final sort of slightly different situation is a sloping loss. This is a patient with a mastoid cavity that didn't have good hearing after reconstruction. And once again, he's getting a good benefit, but not quite so much because of his high frequency sensorineural loss. But again, excellent benefit with the in-aided comparative to the soft band Baha. So the anecdotal reports from the patients are that the system is comfortable, that the sound is quite natural, that the system is helpful for listening in noise, and I was particularly interested to hear this from the single-sided deafness patients, that they found a benefit in background noise, which is not what we've really seen so much with the Retract or even the percutaneous Baha. The Treacher Collins lady reports it helped with her work situation. She works in an industrial kitchen, and whereas she couldn't hear her colleagues with a regular conduction aid, she can hear and understand them. She can with the osseous system. So she thinks that it's fantastic. It's useful for picking up environmental sound, and obviously it's helpful in the head shadow effect. But I was also very interested that Saji's friend is a very keen windsurfer, and he likes to windsurf with the osseous system. He's got a waterproof system to retain it, and he feels that he can turn and enjoy the localization that he gets with it, which in theory I wouldn't have thought he'd really get, given that it's single-sided deafness. And in his case, I did toss up whether he should be having a cochlear implant or this system, but it's pleasing that he's getting a good benefit. So again, these are initial conclusions, and this is the beginning of a multi-centre international trial. The outcomes have been successful. The surgical procedure is straightforward, and hopefully it will be a good prototype. So interestingly, in Sweden, there's been similar studies with the bone conduction implant, and this is from Gothenburg. And this device, rather than having attachment to an osseous-integrated screw fixture, is just drilled into a well in the bone. So it's still quite a large device, 12 by 14 millimetres, with a depth of 7 millimetres. And I believe that they secure this by putting a little titanium strap over the top of it. And that has provided good outcomes. There's a picture of the device itself. And this is being now converted to a product by Oticon as I believe the Sentio, and they reported in Osseo meeting that this would be available in mid 2019. So it is some way off, but a similar concept obviously, and I think it will be very interesting to see if the rather than being fixed or secured to a screw fixture, whether being implanted into a recess or well in the bone provides equivalent or better or what the comparable bone conduction is. So I'm grateful to ADSNIC and Emmanuel Milanis for providing these slides for me. And ADSNIC and others have looked at multiple studies. This is a systematic review, only studies with more than 5 patients over the last 10 years. But looking at the aided thresholds versus the hearing loss, cochlear hearing loss, in patients with a variety of types of implants. And I won't go into which devices they are, but the different colours represent different studies and centres. And it's interesting to see that none of them really actually get to the NAL target line. So the reality is that all of these systems are somewhat underpowered compared with what they should be or what we would like them to provide to give optimal hearing benefit. And also there's a variety of fitting effectiveness. So this centre is clearly getting much better fitting with the same device than this centre is. And so we need to be able to optimise the fitting that's done for the different types of devices in different centres. And that just shows, if you're below this line, you get 100% audibility in theory, but when you're getting up here, you're getting zero understandability. So based on maximum output, this is what's being measured, is underamplification is common. The limited leads to low gain settings and compression. A better option is to use the device with a higher output level. And I was surprised to see that in the UK they're using the Baha Retract system, but then putting super powered Baha on that, when you'd think that if they need to get the extra power, they should at least be using a screw fixture rather than having a Baha Retract. So there are, of course, different levels of power available. The standard Baha, the power, and the superpower. This is from the Cochlear company. And in theory, different levels of bone conduction thresholds. But if you're looking at the level of hearing that you're trying to, or amplification you're trying to provide, the more power, the better in terms of the benefit. But with Baha, the great thing, and this is where it differs from, say, cochlear implants for single-sided deafness, is that they can test the system in advance. You can use a test rod in the office or give them a soft band to take home or a headband like this, clip the processor on and test them. And ideally they should take it home for a week and use it in their normal environment and see if they like it, see if they get a benefit. And if they do, you can be very confident that they will get at least that level of benefit with an implant. And that's something we can't do with cochlear implants. We're a bit more relying on statistics and prediction. As part of this sort of pre-implantation trial, Cochlear have just produced the so-called sound arc, which is shown here on a patient wearing it. This is a headband, effectively, meant to be a bit more aesthetic and effective. The Baha clips onto the side again, and provided it's properly fitted, it does give good sound conduction. And the initial reports are that it's easy to use, that the patients like it, and that it's equivalent in effectiveness to the soft band. And certainly this is a good trial, and perhaps for some patients this is a good temporising measure. And often I have patients where we're doing something to their one or other ear, and you basically are taking their better ear out of action for a while, and they can't use air conduction, they can't use a hearing aid, but they need some temporary bone conduction. And this sort of device, I think, is very good for that, as well as simply trialling whether they like a Baha before going ahead with surgery. And Medel are also getting into the field and have produced the so-called Adhere, which is a stick-on system where you can clip the hearing aid onto that. And once again, probably a very effective system as a temporising measure. I don't see this as being particularly a long-term management option for kids like this, but again, certainly a good temporising measure and perhaps even a longer-term measure. So what about the future? Well, this is the Tiki, the totally implantable cochlear implant that we put 3 of these in now over 10 years ago. And this has an internal lithium battery. It has a microphone on the package here, which is obviously a subcutaneous microphone, and it's a cochlear implant. And these patients are all still using the device with benefit, and they can get invisible hearing, but their speech understanding when using this is not nearly as good as when they wear an external processor. So the reality is that none of them use it for day-to-day communication. It just wasn't good enough. But this system, the Carina, is a active middle ear implant. It has a little transducer here that connects to the incus, and this is the subcutaneous microphone. And this system has some built-in noise cancellation. And this has proven very effective. I have a whole of one patient again, and he does very well with the Carina, and he's a farmer from up the country in Victoria where I live, and he's in fact got a bone-anchored hearing aid on one ear, a percutaneous Baha, and he's got a Carina in his other ear, and he actually prefers the Carina, which to me is it's a single subject demonstration that it's relatively effective. So I would be hopeful that this microphone can at least be connected with a cochlear implant to give invisible hearing through with a cochlear implant. And I'm sure at some stage that will become available with some form of better microphone to provide a totally implantable cochlear implant. Whether you can provide a totally implantable bone-anchored hearing aid is another issue though, because once again, you've got the microphone relatively close to whatever the actuator is that's providing the bone vibration, and you've got to have significant separation to avoid feedback. And so I think that to have an invisible hearing with bone-anchored hearing aids is going to be a real challenge, and I'm not sure that is going to be successful. So I'll finish there, and John's obviously getting toey down here. Thank you very much.
Thanks very much, Rob. A couple of questions. Okay, one over here.
Manaha. We got a.
Wait, Manaha. The microphone here. Oh, you want to.
Thank you, Rob. That was a fantastic overview. Really enjoyed it. I worked a bit with Cochlear in our lab developing some of the early piezoelectric stuff, measuring bone conduction and stuff. So a question I have for you is, we know that any passive device has skin in between will drop the high frequencies, just because that's what skin does. It drops, it's a compliance in the system. So any active device, either transcutaneous or implanted active, will do better in the high frequencies than a soft band or anything that goes in a tract. So it was interesting seeing comparisons of the new device versus a soft band, but we'd expect it to be better than the soft band in the high frequencies.
Correct.
So do you have any data showing how it does compared to the bone curve, which uses a much more powerful transducer to try and measure the bone curve?
No.
How does it do compared to the bone curve? On audiogram?
The company does. I don't. And as I say, this is very preliminary, so I'm limited as to what I can show.
I understand.
But my understanding is that the piezoelectric system does have a better high frequency output than the electromagnetic systems.
Right.
And that's
true.
very promising, I think.
Their problem is usually getting low frequencies piezoelectrics. The high frequencies are
Correct.
easier to get, and piezoelectrics by definition do well at high frequencies but have trouble at low frequencies. But you can change your resonances and things. The second question I have is, I play with the Dermalock, the coating
Yep.
abutments for a bit, and I had a couple of really bad reactions to the skin. Have you seen that with the Dermalock coating, or?
No, I haven't. Look, I changed to, as I say, back in 2009. I started using a linear incision and no soft tissue reduction, or very limited soft tissue reduction, and using longer abutments. And immediately, and much better outcomes, and low incidence of problems. And then at the same time, Cochlear, the company, changed to the Dermalock. And I personally don't believe that it was the new coating that made any difference. I think it's a different surgical approach.
Right. Okay.
But I haven't seen any excessive reactions that I'd attribute to the hydroxylapatite coating.
Okay, thanks so much.
I think you see a little bit more early skin and soft tissue reaction if you examine the patients in the early course with the HA coating. And then that kind of quiets down and goes away and hopefully will prevent some of that overgrowth that you were showing.
Yeah, in theory, and you know, Cochlear and I think in Sweden and elsewhere, they've done animal studies showing tissue integration to that Dermalock hydroxylapatite coating. But and it may be real, but I'm not so sure. I think it's you know, you get such skin movement and stuff like that there's going to be some shearing forces and things around the abutment, and to what extent it's a coating, what extent it's just having a non-reactive interface where you can get some skin keratin or skin ingrowth so that it remains clear. Interestingly, that my dental colleagues tell me that, you know, with the oral cavity and dental implants, that it's well known that if you have a depth of soft tissue greater than 12 millimeters, you have problems. So I think it's related to that depth of tissue, and it's not so much the coating. There's no.
Here. No, don't ask.
Thank you. I want to ask about the age. From which age you can put the Baha if you have unilateral atresia?
Well, depends on where you are, which company. There are some rules. I think in which country. FDA, it's not before age 5. I personally haven't used for single-sided deafness at all in children. I'm not sure that there's sufficient evidence of benefit for single-sided deafness in children, so I don't have any experience with children. For bilateral, though, you know, down to even age 2 or 3. But for very young children, you need to use a soft band. Sujana.
Yeah, the problem with doing very young children is that you end up with a 3 millimeter implant, and the extrusion rate for 3 millimeter implants is significantly higher than 4 millimeter implants.
You've got 3 millimeter implant, but you've only got 2 millimeters of bone. That's the problem.
Yeah, it's a real mess. So the longer you can have that child use a soft band, which really works very well, and then when they're 5 or 6 and you can put in a 4 millimeter implant, that will last them a long time.